Hi friends, in the series of flexible bronchoscopy, first one is bronchoscope types. Anybody who want to do bronchoscope, first of all, he should know methodically many things, of which the most important thing is he has to know what is bronchoscope and what are the types of bronchoscope available, what is the newer advances, how you can purchase a bronchoscope that is suitable for practice. All these things you should know. You can see three scientists, actually these three scientists, Gustav Killian, Chevalier Jackson, Shigeto Ikeda, and these are the people are probably fathers of bronchoscopy. If you go to the minor details, actually Gustav Killian is the one is considered to be father of bronchoscopy because by removing he happened to remove a pork bone from a farmer's airway. Thereby he is given the idea that we can explore the airway. Next, in 1904, a scientist from Philadelphia, he has done a lot of changes in the rigid scope, particularly in the optical system, and he also removed a lot of foreign bodies from the many children, and it is called, that is Chevalier Jackson is called as father of modern day rigid bronchoscopy. Actually it is the Japanese scientist Shigeto Ikeda is the one who developed fiber optic bronchoscopy. So fiber optic bronchoscopy is a type of flexible bronchoscopy. He developed this in 1967. There are two types of bronchoscopes. One is the flexible, one is the rigid. Actually, our practice is mainly flexible bronchoscope. You should also know something about the rigid bronchoscope, and the most important difference between these two is flexible bronchoscopy can be done either in the local anesthesia with or without sedation, whereas rigid bronchoscopy always require general anesthesia. Look at the way we are doing flexible bronchoscopy and the rigid bronchoscopy. Actually, flexible bronchoscopy is the one, here it is something like a cord-like instrument going through the purvia naturalis. Initially it goes through the nose, then it goes through the larynx, trachea, then like that and all. Whereas rigid bronchoscope is a rigid tube, and it is mainly those days used for removal of the foreign bodies, but still for removing the foreign bodies rigid bronchoscope plays a major role, and it is also used for many therapeutic procedures. But after large working channels, even flexible bronchoscopy also used for many therapeutic purposes that we are going to discuss. This is a rigid bronchoscope, how it looks and all, and I don't want to go much about that. We are going to talk about the flexible bronchoscope. What you are seeing is the fiber optic flexible bronchoscope, and can you see that what is the dark area and the white area? The white area is the one that is possible with the rigid bronchoscope, whereas the black area denotes the extent to which flexible bronchoscopy can go deeper. So what I want to say that with the flexible bronchoscopy, because of the smaller size, we can visualize up to fifth order. Of late, very small bronchoscopes are available, even goes little down also. And another advantage is the distal end of the flexible bronchoscopy can be flexed, that I am going to show that. And in that way, by flexing the distal end, we can also see the upper lobes. That is not possible with the rigid scope. So I already said, when compared to rigid bronchoscope, it is really a atraumatic experience, can be done local anesthesia with a constant sedation. Flexible bronchoscope, there are three types. Actually, the first one is, what is this? It is a fiber optic bronchoscope. Actually, fiber optic bronch. Here we have to do the bronchoscopy by seeing through the eyepiece, and this is one fiber optic bronchoscopy. It is a type of flexible bronchoscope. The other advance is the video bronchoscope. Here you cannot see, here nothing is eyepiece there. Here the camera is mounted, so it is get connected to the monitor. So you have to do the bronchoscope not through the eyepiece but looking at the monitor. That is what the video bronchoscope. There are hybrid bronchoscopes also available. Actually, to reduce the cost, they incorporate both these technology, particularly the fiber optic as well as the rigid bronchoscope technology and all. Coming to the parts, actually this is a flexible fiber optic bronchoscope. Actually, can you see this key diagram? Actually, this we have drawn long back, and long before we have draw this one. And this is a proximal end with the eyepiece, and in the proximal end we can see the lever. Okay, the control lead, or sometimes lever it is called. By adjusting the lever, we can make that distal end can be flexed or extended like that. And again, this part is called the shaft, and this is the distal end. And here it is a connecting cord that goes and attach it with the light source. Those days we use helium source. Nowadays xenon source are available, and it goes for long hours. That's an advantage. Can you see the flexible fiber optic bronchoscope? It is something like a cord, like it is a relatively, when compared to the video bronchoscope, it is less costly. I can see that it is eyepiece, and this is the one that working channel here through which you can pass the accessories, or you can also push the normal saline, and it is comes like that. And this is the distal end. Okay, and here is a connecting cord, and it gets attached to the light source. As I already said, flexible fiber optic bronchoscope made up of fiber optic bundles. Roughly, if you see here, there is roughly 15,000 glass fibers are the one, and through which the light travels, and the image also travels, and the image travels by repeated internal reflection. Actually, it's something like a prism, thereby transmit the image. And I already said we have to do the procedure seeing through the eyepiece. And this is the one, since it contains fiber optic bundles, it get subject to damage. That's the reason why we should not acutely bend the fiber optic bronchoscope. If anybody sometimes have a tendency to keep the bronchoscope in other hand, and if you are able to bend the bronchoscope, the bundles get damaged. That's the reason why fiber optic bronchoscopy should be always hanged. It should not be, you should not make a acute bending and all. This is a distal end. Actually, can you see the distal end? And if you look at that, you can see the working channel. This is a working channel, and here is the light guide. Light comes here, then through the objective lens that image goes, and that is the way fiber optic bronchoscopy is designed. And coming to the distal end, actually it can be bent 100 degrees down and 160 degree up. In that way, this is a cut section at the distal end of the flexible fiber optic bronchoscope. Now we will go to the video bronchoscope. As I already said, there is no eyepiece, and it is a camera is mounted here. Actually, the image processor is here is a CCD chip. Okay, I will tell about what is CCD chip. Actually, this CCD chip is placed at the tip of the bronchoscope. Okay, and that converts light into electrical signals. CCD chip is otherwise called as charge coupled device. Charge coupled device, and the principle is something like that. When the light strike the CCD pixels, then it converts into electrons, and that electrons are carried to the computer. Then the computer generates the image. That is the way it. And actually, these CCD tip are placed at the tip of the bronchoscope. That is the reason why initially they are all very larger size. Now of late with a lot of advances are happening. Even similar to the fiber optic bronchoscope, the video bronchoscopes also available with a smaller size video bronchoscopes also available. Look at the flexible video bronchoscope sizes. Starting, actually the outer diameter is taken as a size, and the size varies from 2.2 millimeter, 2.8 to 3.5, 3.6 to 4.9 like that and all. Actually the smallest one is the 2.2, but it doesn't carry any working channel. Actually that is why some people may purchase wrongly. If there is no working channel, I think it is very difficult to suck or sometimes put normal saline and all. That is the reason why always I advise you can either go for a 2.8 millimeter or 3.5 millimeter, and both these things are having a working channel of 1.2 millimeter, and generally the working length is around 500 to 600 millimeter, and I already tell about the deflection, what is happening in the tip, and I think before buying the bronchoscope you should buy the bronchoscope for example neonatology. Person who is interested in the field of neonatology purchases the bronchoscope, he has to go for 2.8 or at least 3.5, whereas people who do lot of bronchoscopy in a younger child, he can go for 3.5 or 2.8 millimeter. Better not to go for 4.9 and all. Actually this is a size with a working channel of 2.2 millimeter. We always go for some therapeutic procedures. People who want to do a lot of therapeutic procedures, I think they may better go for 4.9 with a working channel of 2.2 millimeter and all. So to make it very simple, if you want to practice a neonate or over the premature children and all, go for 2.8 millimeter, and 1 to 5 years go for 3.6 millimeter, and above 5 years and all, probably I think many people will have to carry two, either 2.8 and 4.9 or 3.5, 2. I think that's the best way and all. But considering the cost, if you want to decide to purchase only one bronchoscope, choose accordingly. And again, this first unit that actually this was given to us, donated, and this is a bronchoscopy unit. Can you see the nice, everything is there. This is a light source, camera, monitor, bronchoscopes, and computer. All these things in a trolley you can nicely arrange, and the trolley can be moved to a place. But ideally it can be kept in a bronchoscopy unit. That is always better. Otherwise sometimes people can misuse and all. It should be properly kept in a room, and the bronchoscope should be very nicely organized, and it should not be if you want to do a bronchoscope, the bronchoscope should be very attractive to the children with a lot of balloons or something like that. Then only they won't cry and all. Coming to one or two slides about the indications. The common indications for the flexible bronchoscopy are these things. Three things I can say. That first is a child having a persistent infiltration in the X-ray, particularly atelectasis or acute atelectasis. These are the children really benefited with the bronchoscopy. Actually, bronchoscope reopened the atelectasis and they become instantaneously normal. Any stridor is nothing but partial compression of the extrathoracic airway, and if it is a prolonged one, or if it is neonatal period or from the infantile period, we have to investigate the child. And again, persistent wheezing or a focal wheezing warrants bronchoscopy to rule out foreign body and all. And if you suspect endobronchial pathology or foreign body, and if foreign body is suspected, and if you are very damn sure child is showing the obstructive emphysema and all, or a collapse, you straight away go for a rigid bronchoscopy. Or if it is echocal, you have not come to any conclusion, then the child may be subjected for a simple procedure, when compared to rigid is really a more invasive. So you can subject a child for bronchoscopy, that is a flexible bronchoscopy, confirm the foreign body, or if there is no foreign body, no need to go for rigid bronchoscope. I already said, when you suspect, if you manage a child with a segmental lesion means collapse consolidation. If you a strong suspicion of TB and all, or if the child is having a big consolidation or collapse consolidation, or in that case you have to do over a bronchoscopy to rule out the endobronchial TB. And in the evaluation of the hemoptysis, it plays a major role. Above all, bronchoalveolar arch can be possible only with the flexible bronchoscopy. And with the flexible, I think we are going to talk about the BAL separately, and it plays a major role in the diagnostic workup. I said, any child developing either a wheeze or stridor or any noisy breathing, you have to rule out congenital causes. There are so many congenital causes, starting from the cyst. I think cyst may appear in the vallecula, or the child may have a laryngeal web. Sometimes it is called glottic web, or sometimes maybe laryngeal cleft, or you have to rule out tracheomalacia, bronchomalacia, or tracheobronchitis. All these could be possible only with the flexible bronchoscopy. Even with the imaging, even with the reconstructive imaging and all, you cannot make it all these diagnoses could be possible only with the directly seeing the structures. Then you should make a diagnosis. In fact, making a tracheoesophageal fistula, particularly H-shape of fistula, it could be possible only with the bronchoscope. And I already talked about the acquired some causes, and these are the conditions you have to child require bronchoscopy. Of late, the therapeutic indications also increasing with the flexible bronchoscopy because of the availability of the larger channels, and we can do difficult intubation, or we can also put tracheobronchial stents, and you can also do a cryobiopsy. All these could be possible with the flexible bronchoscopy. I think we are coming to the end. I think, thank you. Probably we covered first part of the flexible bronchoscopy, that is the bronchoscopy types and the knowledge about the bronchoscopy types, and we will meet again in another lectures, particularly probably procedure or pre-procedure. All these things we talk separately. We'll meet again. Thank you very much.